Hypertensive disorders in pregnancy are important causes of maternal and perinatal death and disability. It can affect several organs and is then called preeclampsia, severe preeclampsia, or eclampsia. It can occur during pregnancy, delivery, and in the early postpartum period. Definitions: hypertension is persistent high blood pressure, 140 mm mercury systolic, or 90 mm mercury diastolic, or higher. Preeclampsia is new-onset hypertension after 20 weeks gestation with protein in the urine. Severe preeclampsia is any hypertension with one or more of the following: severely elevated blood pressure, 160 mm mercury or higher systolic, or 110 mm mercury or higher diastolic, or persistent severe headache behind the eyes, or visual disturbances like silver lights or blurry vision, or persistent upper abdominal pain from the liver, or respiratory distress caused by pulmonary edema, or decreased urine production, less than 400 milliliters per day. Eclampsia is when a pregnant woman develops generalized seizures with no other obvious cause. Usually, these women suffer from preeclampsia, though 10 to 20% of women with eclampsia have a normal blood pressure. Consider a differential diagnosis, like cerebral malaria or meningitis. Causes: preeclampsia is caused by pregnancy and cured by termination of pregnancy. The specific mechanisms for the development of preeclampsia are not fully understood, but the placenta and a hostile reaction from the woman's body to the implantation of the placenta are central. Hypertension in pregnancy is therefore also an important risk for the fetus, for intrauterine growth restriction and intrauterine fetal death and birth asphyxia. How to diagnose? All pregnant women must have their blood pressure measured at all visits to a health facility. If an elevated blood pressure is identified, it should be confirmed after the woman has been resting in a sitting, slightly reclined position for 4 hours. If severe preeclampsia is suspected, you should not wait 4 hours to repeat blood pressure. Instead, begin treatment immediately. If hypertension is diagnosed, perform a urine dipstick to check for protein and assess signs of severe preeclampsia, such as headache, visual disturbances, dizziness, nausea, and upper abdominal pain. Management of hypertension. The management of hypertensive disorders in pregnancy depends on the severity of the condition. Women with gestational hypertension or preeclampsia with no severe features should be seen twice a week until 37 weeks when they should be delivered. They should be warned and advised to seek care if experiencing danger signs: headache, visual disturbances, dizziness, nausea, and upper abdominal pain. Women with gestational hypertension or preeclampsia without severe features do not need to be admitted if they can be seen twice a week and can access care immediately should they develop severe features. See practical procedure for further information. If the blood pressure is above 160 mm mercury systolic or 110 mm mercury diastolic, they should remain at the health facility and IV or oral antihypertensive treatment should be started. To keep the systolic blood pressure below 160 is the single most important task to prevent cerebral hemorrhage, which is the cause of half of the deaths due to preeclampsia. Use a fast-acting antihypertensive drug to reduce severely elevated blood pressure. Hydralazine IV or labetalol IV are recommended drugs. An alternative, which should be used with caution, is nifedipine orally. Labetalol orally and methyldopa orally are widely available antihypertensive drugs which can be used to treat moderately elevated blood pressure and serve as a basic treatment together with IV treatment. See Action Card on Management of Hypertension and Drug List for details and treatment regimen. Severe preeclampsia and eclampsia. If a patient has severe preeclampsia or eclampsia, this is what you do. 1. Call for help. 2. Assess vital signs and fetal well-being. Control blood pressure to under 160/110 millimeter mercury. Monitor fluid in and output, and plan delivery. 3. Check airway and breathing. 4. In case of uncontrollable high blood pressure despite treatment, or central nervous system symptoms, headache, visual disturbances, dizziness, hyperreflexia, or even convulsions, manage with magnesium sulfate. In case of convulsions, don't panic. Convulsions are self-limiting. While convulsing, prevent the woman from trauma and tilt her to one side. 5. Insert IV lines. 6. Give magnesium sulfate, the safest and most effective way to treat and prevent convulsions. In order to reach the therapeutic level, you must give the drug intravenously. Never give magnesium sulfate intravenously fast, as this causes heart arrest. Give the woman 4 grams of magnesium sulfate intravenously, slowly, over 5 to 20 minutes, using a 20% solution. If magnesium sulfate 20% solution is not available, see drug list for preparation from 50% solution. Now check for toxicity. The first sign of toxicity is loss of tendon reflexes. A more severe sign is respiratory depression with a respiratory rate of less than 12 per minute. After the intravenous administration, you have reached therapeutic level, and if there are no signs of toxicity, proceed directly to giving 2 doses of magnesium sulfate, 5 grams deep intramuscular injection with 1 milliliter of 2% lidocaine, 1 in each buttock. Every 4 hours, you must check for signs of toxicity. If there are none, you give another 5 grams of magnesium sulfate with 1 milliliter of 2% lidocaine intramuscularly. See drug list. In case of signs of toxicity, you do not give the intramuscular dose of magnesium sulfate. If the respiratory rate is less than 12 per minute, give the antidote calcium gluconate, 1 gram intravenously, slowly over 3 minutes. At heart arrest, call for help. Start resuscitation with chest compressions and ventilation, and give calcium gluconate, 1 gram IV push with no delay. Therefore, calcium gluconate must always be available if you administer magnesium sulfate. Pay attention to urine output, since intoxication is seen in patients with an output of less than 30 milliliters per hour averaged over preceding 4 hours. 7. Management of a woman with other types of severe preeclampsia. 8. Put in a urinary catheter and write down fluid in and output every 4 hours. 9. Monitor each half hour respiratory rate, blood pressure, tendon reflexes, and fetal heart rate. Pulmonary edema caused by fluid overload is another important cause of maternal mortality from preeclampsia. It presents as breathing difficulties and fast respiratory rate, 22 or more per minute, and should always be managed as a life-threatening emergency. It's caused by fluid overload, and therefore the fluid balance must be controlled thoroughly. The total fluid intake, oral or IV, should not be more than 1 liter per 12 hours. At pulmonary edema, the control of the blood pressure is also of central importance. Also administer oxygen if available. Diuretics is usually discouraged but can be necessary to administer in low doses. 11. Plan the delivery. Once the patient is stabilized, she must be sent with escort to a referral hospital. At eclampsia, a rule of thumb says that delivery must take place within 12 hours. At severe preeclampsia, within 24 hours. If the gestational age is between viability and 34 weeks, and if the mother is stable, you might decide to postpone delivery up to 48 hours for steroids for lung maturation to have effect.